And Dr. Schade, Dr. Casanova just mentioned the advisory committee that was established as a result of the legislation, which you're the chair. I understand we also have one other DCMS member on that advisory committee. Who else makes up that advisory committee?
We have Dr. A.J. Kirk, who is an emergency room physician. So we have pain medicine, which what I represent, and then emergency room medicine. There's also a surgeon on our committee. There's a family practice doctor, and there's a psychiatrist. So those 5 specialties are actually on the committee.
So it sounds like medicine is very well represented as the implementation goes forward.
Yes, and that's by design. The legislature wanted to make sure that this was a clinical tool. It was going to help the doctors and help the patients, but they also have pharmacists represented on that, the mid-level practitioners. There's a PA on the committee. There's a dentist on the committee, an oral surgeon, and then 2 people from IT technology. In other words, the people that are developing the software and regulating this.
Excellent. So it sounds like there will be a well-rounded voice of practitioners considering all aspects of the implementation.
Yes, sir.
Good. Talk a little bit about the funding. I know in the legislation there was $5 million allocated for an initial implementation. What is the long-term strategy in regards to continuing the funding for implementation of this program?
The short answer is we don't have one, and that's very worrisome. To get this started, the last legislative session used about $5 million from the rainy day fund. This is a one-time exception to do this. So we've got to come up with $5 million every 2 years. That's just to fund the contractor that supplies the software to the pharmacy board. Then on the provider side, we have to have our software to do this. And so depending on your EHR contract, it may be part of your standard package, or it may be an upgrade that you have to pay for. Or if you have paper charts, then you're going to have to use an independent e-prescribing access software. And some of them are free, some of them cost money. So there's a price cost for the provider. And what we're worried about, and my next committee meeting is April 6th, to talk about where's the next $5 million coming from. What we're worried about is kind of knee-jerk, we'll just let the doctors pay for it. Mm-hmm. We just add another $50 or $100 every time we renew our license. That's not acceptable to me. Is it acceptable to you, Mark?
No, and I think the point you make is that that is one of many reasons physicians need to have a seat at the table. Yes, and that's the inherent value in DCMS and TMA leading the advocacy behind that. What we also don't want is we don't want patients to be hit with a bill. So I think the point is to look to the state and find an equitable way to implement these rules, which are ultimately focused on safety, but not have it impact our patients, not have it impact our practices from an administrative burdensome overhead, and just finding that funding mechanism that'll work moving forward.
I agree.
Yeah, that's a great point, Dr. Casanova, that if it's a priority for safety for patients, safety for practitioners, that the state should make an investment in funding that program going forward.
Absolutely, and I think it's also important to understand, let's be candid and honest, we are faced with a myriad of burdens on a daily basis from the practice of medicine standpoint. Being in a room face-to-face with the patient, that's the easy part, okay? It's the prior authorizations, it's checking the PMP. Some of these things aren't going to go away. And I think we also need to have that equal understanding. The emphasis of this is a patient safety emphasis, but it also protects physicians, and it also protects pharmacists. So I think if we can reframe how we look at this, the implementation should be smoother. And I think the key is funding and ease of access, so that physicians aren't having to click 20 times to upload the PMP versus a 2-click auto reference, and up comes the patient's prescribing profile.
And to that point, at our first meeting, which was in January of the committee, the family practice representative said it was taking him an average of 6 clicks. And that doesn't sound like a lot, but if you're doing it all day, day in and day out, it becomes overly burdensome.
Yes, it is.
It should be that for each specialty, and that's what I'm hoping for by getting the feedback from our members, John, is that we can customize this to the specialties, because it's very different in the emergency room, pain medicine versus oncology, what we're looking for.
Mm-hmm. Speaking of the specialties, Dr. Shaddy, are there any exceptions to physicians having to check the PDMP prior to prescribing?
There are two. If you're treating a cancer patient or the patient's in hospice, that has to be clearly documented in your medical record and on the prescription, so the pharmacist knows it. So that's a group that you don't have to check. The other one is if you make a I can't remember how they worded it, but a due diligent try to access and you can't, let's say the internet's down, okay, or some other type of glitch that's out of your control, you just document that and move on.
Excellent.
Stay tuned for more. For more information about this topic and more, visit dallas-cms.org.